Good afternoon. My name is Joan Reed. I'm Dean for Diversity and Community Partnership at Harvard Medical School, and I want to welcome you to today's session. The number of registrants is close to 500 for our webinar on mental health and wellness for healthcare providers. Our registrants include healthcare providers, members of the public health workforce, our medical students and graduate students, administrators, people from community organizations, and individuals from our community and across our country. Today's webinar is sponsored by the Harvard Medical School Office for Diversity, Inclusion, and Community Partnership. The mission of our office is to advance diversity and inclusion in health, biomedical behavior, and STEM fields in ways that build individual and institutional capacity to achieve excellence, foster innovation, and ensure equity in health locally, nationally, and globally. Our efforts support the career development of junior faculty, trainees, and students, identify and train leaders in academic medicine and health policy, and provide crucial programs that address pipeline issues. Today's webinar, Mental Health and Wellness for Healthcare Providers, is offered through our DICP Equity and Social Justice Initiative. In the fall of 2016, committee of faculty, trainees, students, and staff representing our entire community established an equity and social justice series to address health disparities, social determinants of health, leadership, health systems, health policy, and areas affecting vulnerable populations. Since 2016, we have an average of 10 to 12 programs provided annually by our office and in collaboration with our Harvard Medical School affiliated institutions. ESJ, or Equity Social Justice events, focus on 4 areas: history and context, culture and environment, health disparities, and leadership skills. This year, our series tackles health issues that often impact disadvantaged and vulnerable and underserved patients. Our conversations and speakers will address not just defining disparities, but also discussing interventions and what we can do about disparities in our community, our hospitals, locally and nationally. Today's session is a second in our series that really looks at equity and social justice and the impact related to COVID-19. The impact on our patients, our community, but also the healthcare providers who take care of the members of our community. Dr. Alden Landry, who coordinates our ESJ discussions, will share more on this series and what our goals are. And he is also the moderator for today's session. Dr. Landry is an emergency medicine physician at Beth Deaconess Medical Center and is the founder of Motivating Pathways. He's an assistant professor of emergency medicine at Harvard Medical School. And I'm so glad to say that he is an assistant dean in our Office for Diversity, Inclusion, and Community Partnership. Dr. Alden Landry.
Good afternoon, everyone, and thank you for joining us for this wonderful presentation. I think it's a timely presentation, and it's an opportunity for us to have a conversation that often flies under the radar, which is discussing mental health and wellness for healthcare providers. This is a second in our series of our equity and social justice webinars where we're focusing on the impact of COVID-19. Earlier this week, we had a discussion focusing on health disparities. And this session is going to focus on mental health. We will make available a recording of this session at a later date. So it will be available for those of you to review at a different time. As we focus on mental health and wellness, I want you to think about who we are considering as providers. It's not just the doctors and the nurses that are providing care for patients, but it's the environmental services and the food services staff. It's our registration technicians and our radiology technicians. It's all of those people who don't necessarily get the shine in these public spaces who are also providing care. And so as we have this conversation, I want to make sure that we include those individuals in this discussion and we think about their needs as well as ours. Next slide. So I just want to go over a couple of housekeeping items. All of your lines are muted, so you won't be able to communicate directly with our panelists. However, if you do have a question that you would like to ask, we will open that up towards the end of the session. You can use the question and answer tab at the bottom of your screen to direct questions, and I will do my best to make sure to bring in as many conversations from all of our participants into this conversation. And again, the recording will be available on the DICP website. Next slide. Again, just want to go over the flow of our event. You're going to hear from 3 amazing panelists in this discussion. And then after that, we're going to open it up for a Q&A session. And I will introduce our speakers shortly so you can hear from them. And we're going to go in the order that you see them presented on the screen. Next slide. So our first panelist is Dr. Ayana Jordan. She is an addiction psychiatrist and assistant professor of psychiatry in the Department of Psychiatry and the director of the Social Justice and Health Equity curriculum at Yale. Dr. Jordan is also the new associate program director at the Yale Psychiatry Residency. Aside from her amazing accomplishments, when I told another colleague of mine that Dr. Jordan was going to be in the panel, they simply replied, "Oh, she's a powerhouse." So I think that says enough about her. We also have Dr. Jennifer Potter. She is a professor of medicine and advisory dean for the William Bosworth Castle Society at Harvard Medical School. She's the founding director of the Women's Health Center and co-chair of the Fenway Institute. At HMS, she serves in a number of other roles, including faculty co-director of 2 courses with an emphasis on sexual gender minorities and trauma-informed care. And then last but not least is a good friend of mine, Dr. Kevin Simon. Dr. Simon is completing a fellowship training in child and adolescent psychiatry and addiction medicine at Boston Children's Hospital and Harvard Medical School. He completed his general psychiatry training in the Department of Psychiatry and Behavioral Sciences at Morehouse School of Medicine. And he's a graduate of Southern Illinois University School of Medicine. So I think, as you can see, we've compiled 3 wonderful speakers who are going to be able to bring to light an important issue and really help drive home a conversation that needs to happen. I just want to bring up a study that was recently published at the beginning of March in JAMA, and it talked about the role of the impact of the mental health, impact on mental health for frontline providers in Wuhan, China. And the summary of the study basically showed that those who were frontline providers working in clinics that were under-resourced, the nurses and women were more impacted with issues related to mental health issues, insomnia, depression, and overall stress and anxiety when it comes to providing care for patients in COVID. And so I think that's a great backdrop for this study, for this conversation, as we think about what's happening in other parts of the country, particularly our colleagues in New York City, here in Boston, and other places in the US that are heavily impacted with high burdens of disease and low resources in the hospital systems. As we have this conversation, think about those individuals and also think about yourselves when we're talking about mental health and wellness. So I first want to go to you, Dr. Jordan, and start off this conversation. So we're dealing with some trying times for providers. Many of us, including myself, are seeing patients die at alarming rates, much higher than what we would typically see during patient care. Can you talk to us about how how this is impacting mental health providers of individuals who are on the front lines, and how we may or may not have been adequately trained in our medical training to deal with this problem?
So thank you so much. I am happy to answer your question, but I just want to start off by thanking you, Dr. Landry, and the Office for Diversity, Inclusion, and Community Partnership for organizing this event and allowing this platform to happen, because I think it is extremely necessary. Very happy to be here with the esteemed guests, Dr. Simon, Dr. Potter as well. Lastly, let me just give a shout out to all my folks that are here from the American Psychiatric Association, the Black Caucus, friends and colleagues from Yale, and all the people that are joining us today. I'll start off by saying that no, the medical system did not prepare us, period with a T. And, you know, the bottom line is that a lot of us, including people who are on the front lines and those who are not on the front lines, but are just experiencing what is happening during these unprecedented times, are really struggling because there is not necessarily a roadmap of how to deal with this. And we do not know how long this will last. And we are not given the necessary resources that we need from our employers in order to do our very best. Unfortunately, in some hospital systems and some organizations, not only are people not getting the support that they need, but quite conversely, if they do speak up against the conditions that are not safe, not having access to personal protective equipment, or not feeling confident in their ability to perform, that they are being penalized for their actions. So I think that is even more unpredictable, because not only are we not given the resources that we need, but a lot of times we are being punished if we do speak up to protect ourselves. So I say all that not to necessarily be grim, but just to really paint a very accurate picture of what's going on. And so if we're able to think about what is going to happen as a result of really going through this pandemic, many of us will come through and will be totally fine. Part of that is because we're able to access resilience, and really thinking about resilience as a tool that is accessible to everyone. It's free. It doesn't matter what you look like, Black, white, Asian, otherwise. It's accessible to you. And there's many different ways that you can increase your resilience, whether that be making sure that you're exercising physical, mental, emotional, and social wellness, whether that means that you're staying connected with folks. And one of the terms that I'd like to use instead of social distancing is really physical distancing, because now more than ever, we have to stay socially connected to one another while we're physical distancing. And then also thinking about how to practice resilience through connection with a higher power or the deeper sense of meaning. So really thinking about how can we increase our resilience to get through this time, and really focus on that is super important. I do, though, want to transition to those who may not be okay after this is all over. And so what I thought I would do was just put up for folks just what is the DSM-5, and that's a manual that we use as psychiatrists about different disorders, what that looks like for PTSD or post-traumatic stress disorder. And I wanted to compare that to some of the symptoms that healthcare workers are experiencing. Now, just because people are having symptoms doesn't necessarily mean that they're going to have PTSD. But my point is, it is going to be super salient now more than ever to demand that our healthcare organizations provide the support that we will need in case that we do end up developing PTSD, because it's not so far-fetched. So if we think about the definition, let's look at the top part of the slide. In order to be diagnosed with PTSD, there has to be criterion A, which is causation. So that just means that you have to be exposed to an actual or threatened death, a serious injury, or sexual violence. We know that what's happening during COVID-19 does meet criteria for causation. Then thinking about criterion B, re-experiencing. So those are things like having nightmares, intrusive thoughts, flashbacks as a result of this threatened experience, or actually threatened death. And for the diagnosis, you only need one of those. So many of our healthcare workers, and again, I appreciate you, Dr. Landry, for holding up people who are just not healthcare workers, but other people who may have these re-experiencing symptoms during the pandemic. Thinking about avoidance, we only need one criteria from this category. not wanting to think about your thoughts or feelings associated with the event because it's so painful. Then negative alterations in cognition or mood, really having a persistent negative emotional state related to this pandemic. And then finally, hyperarousal. So those are things like not being able to sleep, engaging in self-destructive behavior. So as an addiction doc, thinking about people who are drinking too much or smoking too much or using another substance too much. And then thinking about irritability. And in order to have the diagnosis of PTSD, that has to last for at least 1 month. So we'll see what happens. But I just want to encourage folks, if you're having these symptoms, it is something that we know can happen because of the reality of actually experiencing a threat to your livelihood. But also, I just want to couch that there is something that is called an acute stress reaction, to where if you're having things like anxiety, insomnia, crying more than usual, feeling betrayed, not being able to concentrate, these are all normal responses to what's happening right now. So I don't want to jump to pathologizing what's happening, but I do want to elevate, if these things continue to go on for a month or more, it is okay to access help. You don't have to feel like you have to do it on your own. There are people and places that you can access help. So I think that's super, super important to really think about. One of the things that I'll close with, because I want to make sure that we get to the other panelists and have some time for Q&A, is just really thinking about the importance of feeling all the feels. And it's like, Dr. Jordan, what are you talking about? What does that mean? It means allowing ourselves the space to not have all the answers. So realizing that there are going to be days that we might just cry, that we're not able to function at our normal level because we need to feel all the feels. To give you a tangible example is, as a Black woman who happens to be a physician, just tuning into the disparity that's happening with folks all across this nation. Countless Black folk being hospitalized at alarming rates despite only making up minority of the population is so upsetting. No, this is not my family members per se, but just the conglomeration of dealing with the historical oppression in this country, on top of having to see now us being totally mistreated once again, likely dying at higher rates, is upsetting. And so giving myself that space to mourn, to cry, is not pathologizing, but it's just a normal reaction to the event. And then thinking about how I can practice some of that resilience, staying connected to people who look like me, talking about it with trusted colleagues in order to process what's happening is totally normal. So again, wanting to give space for normal reactions at the bottom, but also just elevating that if these things continue to go on, it is okay to ask for help, and there are systems in place to help. So thank you so much. I look forward to hearing from the other panelists.
Dr. Jordan, I do have one follow-up question. And actually, later on, I do want to talk about what you were just mentioning about the health disparities component of this discussion, because I think that weighs heavily on a lot of us providers who are coming from underrepresented and disadvantaged backgrounds, on how we are seeing patients who look like us more afflicted with this virus. So I want to come back to you at a later point for that question. But right now, I guess, can you maybe speak on what you have seen as far as support for providers from systems, whether it be universities, hospital systems that are in place, that are working well? And then maybe if you can give an example of what people should be doing in order to make sure that they're accessing those networks.
That's an excellent question. I think one of the things that's working well, and this has been employed in many different systems, both academic and non-academic, is allowing people to have the space to talk about what's going on. So for some people, they're calling that town halls. For other people, they're just coordinating Zoom sessions so that people can talk about their experiences. One of the ways to minimize stigma is to call them, support groups or mental wellness groups, not necessarily to call it related to anything that has to do with mental illness, because that will inherently discourage many people from attending. But in these all kind of comer groups, people are able to hear what their colleagues or other people in their community are experiencing and are going through. And then if there is a need for escalated help, meaning that someone has to see a therapist or a psychologist or a psychiatrist one-on-one, there are moderators in this group that are able to check in with the participants one-on-one, and the participants can also access the moderators to ask for help in a private way that does not weigh on their integrity or put them out in any way. So I think that's just a really nice way of thinking about, as leaders, how can we curate these groups where people feel like they have the autonomy to share what's going on with them, and then have expert moderators who are able to kind of weigh in and see who might need help and who might not need help. Some other things that work really well in terms of uncertainty that certain organizations are doing better than others is just being able to provide reassurance for basic needs. So for instance, if you're not able to say like, oh, you will continue to get paid through May, then don't say that. But things like parking will be free if you have to come into the hospital, if you have to come into the work, that's important. Or still having access to childcare needs is huge. There was an email that went out from Yale that said, no matter where you work in the department, no matter where you work on the university campus, you will continue to get paid until the end of May. That is huge in terms of providing reassurance. Thinking about what are some networks so that people can have pet sitters or elderly care sitters so people are able to do their jobs. Really compiling a list of ways in which people's basic needs are being met, because that helps to minimize undue anxiety in the middle of this pandemic. Finally, a system that's working really well is making sure that people have free access to mental health care. So eliminating the need, and a lot of insurers have done this. I know Blue Cross Blue Shield has done this. Aetna has done this, is eliminating co-pays so that people are able to access mental health care without having to worry about financial demands. And I think one of the ways organizations can just make this very sticky for folks is compiling a list of places where you're able to access mental health care freely and in a way that has minimal barriers. So those are all some really good models that have happened both in and out of academia.
Thank you. So next I want to turn to you, Dr. Potter. So it's an interesting time right now in medicine where some people are working while others are not, because of restrictions, whether it's elimination of clinical responsibilities, canceling of elective procedures and surgeries. So I know that there are some providers who are out there who are actually feeling a sense of guilt because they're not, quote unquote, on the front lines working. Can you speak to what some others may be experiencing who are in healthcare but may not be on the front lines?
Definitely, and thank you so much for the question. It is a pleasure to be here today with everyone. Could I have the first slide, please? I think that it's striking how many rapidly changing and seemingly contradictory feelings healthcare workers are having in the middle of this crisis. And this makes sense, as Dr. Jordan was saying, because we're all traumatized by what's going on right now. And as human beings, we have a finite number of ways we respond when we feel threatened, the so-called fight, flight, or freeze reactions. So it's not really surprising that we're manifesting the full range of responses along this continuum. When we're in the fight mode, we may be irritable, we may lose our tempers, we may attempt to defend ourselves, to self-protect. When we're in flight mode, we may be anxious and afraid, and there's plenty of reason to be afraid right now. And when we're in freeze mode, we may feel numb and even detached from other people. And I think what's important is that our experiences seem to differ a little bit depending on our work assignments right now. And they also depend on the trauma burden that we've been exposed to across our previous lifetime. Because each new trauma sort of layers on top of other ones, and there is tremendous resilience that one gains from going through traumatic experiences, as Dr. Jordan has described, but also each new trauma sort of re-enlivens the previous ones, at least for a little while. So far, we've talked mostly about the reactions of doctors and other healthcare workers who are on the front lines, and they're rapidly becoming more and more physically and emotionally exhausted. One of my colleagues recently told me that he writes down the first names of all the people who die on each of his shifts as a note to self in order to honor them and never forget them. And he added, as he was speaking to me, but how much death can one person bear? Then there are the people who are working from home, and this group is challenged in different ways. They're spending long hours in front of the computer covering for their colleagues on the front lines and doing telehealth visits. Often they're juggling childcare and homeschooling simultaneously. And in spite of all this, they feel disempowered. Sometimes they just feel unproductive. They may even, at the extreme, feel unuseful or useless. And they have guilt for having feelings like relief that are not heroic. Feeling relieved, of course, is normal when you're under threat, but it does not feel noble. And then there are the healthcare workers who are sick or quarantined. They are separated from their loved ones and sources of support. They face uncertainty around whether or not they're going to become seriously ill, and they're at risk for both feeling abandoned by and perhaps wanting to abandon their professions. One of my colleagues who was quarantined recently told me, if I survive, I don't know if I'm ever going to be able to go back to work. Regardless of their specific situations, all of these healthcare workers can benefit from similar interventions. They need a safe space to vent. They need to be heard. They need their experiences to be validated. They need the systemic injustices they have faced to be acknowledged. They need their autonomy to be respected. They need help, sometimes making a self-care plan, and they need access to resources to help them recover and heal.
Well, thank you, Jenny. I want to pivot to another space that I know that you are really strong at, and that's support for medical students. And as we think about medical students in their role, or maybe some may be feeling a lack of a role during this COVID pandemic, can you talk about what medical students are feeling now and what they may, with the stresses that they may be under as they're going through their medical education?
Absolutely. And if I could have the second slide, please. I think that the picture on this slide sort of says it all. Just like practicing physicians and other healthcare workers, medical students are having a wide variety of feelings in response to the pandemic. And everyone has experienced a lot of loss. Preclinical students living in dorms had to move out with almost no notice. Some students went home to their families, but this wasn't possible for everyone, especially international students, because of cost and travel restrictions and immigration concerns. Preclinical classes were quickly moved online, and while Zoom allows for plenty of discussion in small groups, it's just not the same as being in class with ready access to your friends and support system. And some students have family members who are now gravely ill, and some have already lost family members. Students in the clinical years have had their clerkships halted for several months. and will continue to have them halted for some time more. There is a lot of uncertainty and stress around this because core clerkships are a time when most students determine their future specialty. For students who will be applying for residency in the fall and have a finite number of remaining months in which to do advanced rotations, there's uncertainty around how they'll be able to optimize their applications. And for fourth-year students, long-awaited ceremonies like graduation and weddings have had to be canceled, and students won't get to have the break they were hoping to have to refuel before starting their internships. So students have many, many feelings about all of this uncertainty and loss: fear, anxiety, sadness, disappointment, and outrage. But perhaps the greatest challenges students have had to grapple with are the shortcomings of the healthcare system that have been so starkly highlighted during this pandemic. The PPE debacle has led some students to feel deeply disillusioned by the expectation that a doctor will do their job despite being insufficiently protected and risking harm to themselves and their loved ones. They are saying, "This is not what I signed up for." Others are horrified by the COVID-related healthcare inequities that are so blatantly obvious right now. Just like the rest of us, students may react to all of these stressors with fight, flight, or freeze type reactions. Some students are advocating strongly for their needs at the medical school level and getting involved in a broad range of COVID-related community service opportunities. Others may feel isolated, alone, panicked, paralyzed, or numb. So it's absolutely crucial that we reach out to our students to support them during this difficult time.
You know, I think that one of the things that I personally struggle with is this conversation on how we refer to healthcare workers at this time. And oftentimes you hear people calling frontline workers heroes. And it's not language that we typically attribute to doctors and nurses and paramedics and so forth. Can you talk about what the use of this language can mean, both positive and negative?
Definitely, I have strong feelings about this one. Could I have the next slide, please? I think that the hero verbiage that we hear right now is an attempt to thank healthcare workers for the incredible courage and bravery and resilience that they're showing. But there are a lot of problems with it. And I would start by saying that one of the challenges we face in medicine is a culture of perfection, as you can see on the left side of the slide. This means that we somehow think that we should be able to handle whatever comes our way and that we're lacking if we ask for help. That's a very dangerous belief to have right now because we're all traumatized and we desperately need support. But because of this culture of perfection, we can also be exceedingly hard on ourselves when we don't live up to our own expectations of a doctor that is supposed to be, in somebody's eyes, selfless, and according to this current rhetoric, heroic. These are not my ideas of a doctor, but they're out there. One of my colleagues described entering a patient's room wearing his PPE, seeing the fear in his patient's eyes, and then noticing that alongside his desire to be fully present and provide comfort were two thoughts. Don't get too close while listening to the lungs, and is this the time that I'm going to become infected? These thoughts are part of the normal survival instinct, but when we expect ourselves to act like heroes, they can make us feel terribly torn. The language of heroism is also used to distract us from the fact that some people don't have any choice in the matter. High coronavirus infection rates among food service and sanitation workers, for example, result from social inequities that lead them to be just a paycheck away from losing their homes, their cars, their health care. And if calling them heroes deflects from how broken their compensation and job protection and other protections are, we desperately need to find different language. And lastly, the rhetoric of heroism leads to another unacceptable consequence. It silences the so-called heroes. The cost of being labeled a hero in the COVID era is that in return, you are meant to accept your halo without calling attention to all of the systems failures that contributed to where we find ourselves today. Unwilling sacrifice is not heroic, it's a tragedy. And healthcare workers are not heroes. We are human.
Thank you for sharing that. And it brings up a couple of emotions for me. One is, I remember a few years back when LeBron James and a number of other athletes were speaking out about injustices, and someone retorted, "Shut up and dribble." And, you know, we think about us as doctors, it's shut up and take care of patients. And is that a fair way to treat us as we're doing our best to care for patients? And I think the other great point that you just brought up was about how we, many of us in healthcare, especially those who are in environmental services, who are food service employees, are working in highly infectious, highly contagious areas, putting themselves at risk, but have very limited access to resources beyond that. And so if they do get sick, what are the implications on their family? And that's creating a lot of stress in families. And so with that, I actually want to turn to you, Dr. Simon. So we've been talking about COVID and healthcare workers, but mostly talking about it as if we practice in a vacuum. But we take all of this home, and what Dr. Jordan was saying earlier about, you know, the stress, the anxiety, the sleeplessness, and all of that, that comes home with us. And we take this home with us. And so can you talk about what this may be doing to us when we go home and we're not wearing our scrubs and we're not wearing our PPE? And then also for those of us who have families and we have children, what is the impact of that stress that we're bringing home?
Right. So much like Dr. Jordan, Dr. Potter, thank you for even having and opening this discussion, because unfortunately we're not generally having it. To your question about, you know, we don't live in a vacuum, you're correct. You know, oftentimes the healthcare workers and hospital staff, our parents, our siblings, our, you know, grandparents, and kids, it is impacting us. And so there was a recent survey by the Kaiser Family Foundation that found, and this was in general to adults, that over 40% of us are struggling with social isolation. And by struggling, meaning feeling the stress of it, even though we know that it's an appropriate thing to do. When you then pivot that to the healthcare providers and those that are in the service industry, it's hitting us from multiple vantage points. And I recognize it in the patients and families that I see, because some of them, the parents are indeed healthcare providers. And there is a mixture of, to Dr. Potter's point, I'm supposed to be this hero and supposed to go into work, and my kid, let's say it's a preteen, is also scared that mommy's going to work, because does that mean mommy's going to get coronavirus? Or daddy is self-isolating in the basement, and so I don't see daddy for a week when he's on service. So what I'm trying to do to orient parents is have factual conversations about what is happening. We can't obviously gloss over this. This is the social isolation and social distancing will be for too long of a period to try to just suggest that this is normal. So one, acknowledge that this is not normal. Acknowledge that the feelings that you have as a parent, the feelings that you have as a healthcare provider, the feelings that your kids have, the disappointment in the activities that they no longer can participate in. So again, if you think about high school or grade school or even graduate school, all these students and kids no longer have a graduation, no longer have a prom, no longer have the teams that they were on. And that's a huge burden, because the reality is we look to sports, we look to graduation, we look to dances to have moments with friends. And so we have to be able to validate each other's feelings. So parents have to validate their kids' feelings, and parents and guardians have to validate each other's feelings. You're going to feel overwhelmed, And unfortunately, we can't project that overwhelmingness. We can't be angry at the COVID, or we can't be angry at the patient. And so oftentimes that does divert to who is next to you, and that is your kid, that is your loved one. And so sometimes we're projecting anger to the inaccurate person. So to your point, this time is stressful for a lot of parents. A number of parents clearly were not homeschool teachers. And so again, we're finding that the stress and anxiety of having one kid or sometimes 4 kids in the home, all trying to be monitored, is causing a lot of tension. And so again, it's about reorganizing what your day is, what the routines are. So this is a very unusual time, and I just try to validate parents and validate kids in the emotion that they are having, because the emotion you have is true to you, and we can't try to force someone to say, oh, be strong because you are a physician, or be strong because you are a dad. It's okay to feel vulnerable. And so I'm allowing parents and my patients to have that vulnerability in a space with me, and hopefully they're able to do that in practice at home with their loved ones via Zoom or Google Chat.
Thank you for that. When you said 4 children, I feel seen with that comment, having 4 at home myself. And I just wanted to get your thoughts on how we can communicate what's going on as healthcare workers with our families. My oldest daughter is old enough to understand about the lack of PPE. Whereas my younger twins don't get the concept. They just know that daddy is working a lot, and that one of my twins prays almost nightly that I don't get coronavirus in my mouth. So how do we make sure that we are doing enough to communicate with our family without burdening them with the details of the work that we're doing?
Right, so this is where creating the structured routine would be very, very important. So for instance, for you're an ER doc, so you're going to do shift work. Is there a calendar that your kids can see that says, okay, daddy's going to work from 8 a.m. to 2 p.m.? Is there a calendar that says what your routine will be when you come home? Okay, daddy's going to shower. We're going to eat dinner together. Also, another thing that I'm advocating for is to, as Dr. Jordan said, social distance but physically connected. So if you're in the same home, have time, no screen, no iPad, no phone, no major news network, and just truly be connected. Play Connect 4, play any board game, because the time that you want is with your kids, seeing you paying attention to them, not seeing you being worried because the next fact came out about the number of deaths or the lack of PPE. So again, depending on the age of the child, regardless of the age of the child, you want to be connected. You want to create a structure and a routine, so that way they're aware of what's happening day to day. Just like, pre-COVID, they had their routine of Tuesday night I did baseball, Wednesday I had my piano practice. The same thing needs to happen even in this time, even if we're staying inside. So I think a lot of times parents have felt overwhelmed. Oh, my kids are here 24/7, but haven't transitioned to creating those structures that were very helpful pre-COVID. And so first thing I would say is, again, get a calendar, put it on a whiteboard, put it on your fridge, and have your kids help you make their own schedule and their routine and keep to it. Again, the other thing you have to do, I mentioned this earlier, is validate their feelings of anger, disappointment, being scared. It's okay that they're scared. It's okay that they're praying with you. You pray with them too. And you continue to reassure them the days you come home, daddy's made it home, mommy made it home. We're gonna be together. And for a lot of us, we're not able, we have families that are in other parts of the country. the other thing to do is be connected. So this would be for the screen, be connected with grandma, with grandpa, right? Are you making time weekly to do the Zoom call as a family rather than just an individual Zoom call because I have a conference call, I have a patient, but as a family, staying connected? Because right now we don't have that opportunity. So I would say be with your kids when you're with them and not be distracted by social media, and designate a structure and a routine that so they're not surprised by what's happening when you come home if there is a different routine that you're now taking to keep them safe.
So I have one other question that I want to ask before we turn to the questions from the audience, and thank you for those of you who are entering questions in that section of the webinar. So just quickly, Dr. Simon, can you talk to us about how we, we don't have a lot of control over our work lives. Our schedules are changing. There's the PPE issues. There's the death and dying that's happening. And so we really don't have a lot of control over our work lives. How can we take that frustration and make sure that we're not misdirecting it and bringing that home to our families and not being another added burden to them when it comes to the bringing home stress from
right.
From
No, it's a great question and a very good point. So despite the fact that we are doing social distancing, we still have opportunities with appropriate protections, right? So putting the mask on so that way you're not sharing anything that you have. Going for taking care of yourself, going for a walk, doing yoga, going for a jog. Like, you have to try and possibly take care of yourself so that way you don't feel that stress. But let's suggest that you are doing those things. How can you still try to mitigate? So if you have another partner or another guardian, can you have check-ins, right? So oftentimes we just go week to week, day to day, and we just start getting in a flow, but we're not actually taking the time to say, hey, how are we doing right now? So that could be at the beginning of the week, it could be at the end of the week, and you can do that with your kids. Okay, how are we doing right now? So that way, if something was said on a particular day that caused a little tension, don't let that tension build up. Have weekly times to check in as a family, check in as a husband, check in as a wife, check in as a sibling. And so I would say that check-ins are important, but the first thing would be taking care of yourself. Now, with regards to taking care of yourself, as Dr. Jordan mentioned, there's been a removal of a cap with regards to accessing psychiatric and psychological care. And so there are a number of providers who are doing telehealth services. And so it would be, prudent now to have someone that is objective, they're not connected to you familially, that you could engage with, vent to, and it's a secure, safe place to do that. So that way you're not inappropriately being more harsh to your child. So I have an example. A mom was getting ready to go into the COVID unit for her service, and she happened to recognize, or at least we recognized together, she was becoming far more strict to her kids. It had not been the case for the past 6 months. And it's like, okay, well, what's different? And it's like, oh, well, you're actually going to be going on a service now. Are you actually potentially fearful of that? Are you scared of that? Is that coming out by now you wanting to make sure that there's sleep at 8 o'clock when that tended not to be the case? So helping her recognize that, oh, I think I actually do need someone to talk to about this. So that way she has that safe space. So I would say taking care of yourself and seeking professional help if it's available to you would be my first recommendation. And then again, having check-ins both with your partner and particularly with your kids.
So thank you. And I just want to now open it up to trying to address some of the questions that we have that are coming from the audience, and also some questions that came to mind for me as I was hearing your wonderful presentations. And so I think maybe I will go to you, Dr. Jordan. It's in your Twitter handle, and it's also a term that you use often. You say, you talk about physical distancing versus social distancing. And can you just give a little bit more clarity around that so people have a little bit more better understanding of what you're meaning by that?
Yeah, thank you so much, Dr. Landry. And if it's okay, I'd like to just comment on a few other points that were made by the panelists. But to answer you directly, I really, really have to stress physical distancing because social distancing is really a misnomer. Right now, in terms of a really traumatic time for many, one of uncertainty, we have to stay socially connected to one another. So we don't want to use the term of socially distancing because we want to do the opposite. We want to stay socially connected while we are physically distancing, remaining apart physically so that we are not transmitting the illness. Also, in terms of just culturally informed care, many people may not understand what social distancing means. For instance, amongst a group of Black folk, they were thinking that socially distancing just means not to hang around people who you don't like. That's not what that means at all. So again, we have to be very clear in terms of our language. Knowledge is power. Let's physically distance, stay 6 feet apart while remaining socially connected. Another thing that I just want to bring into this discussion, let's uplift our folks who are living by themselves, i.e. Dr. Jordan. It is very tough to physically distance when you're in a house alone. And I think a lot of times people are not real about that. Many healthcare workers are now forced into isolation. Maybe they have to physically distance because they're trying to keep themselves safe from their families. Maybe they have to physically distance because they live alone. Who knows? But that can be extremely stressful as well because you're just alone with your own thoughts without any distractions. So again, really thinking about, yes, it is extremely stigmatizing to get help, but if you don't get help, how can you take care of yourself? How can you be well for other people in your life that might depend on you if you're not thinking about your own self? So I always say, people know me. Every Tuesday at 11 o'clock, I am in therapy. Thank God I'm in therapy. And people are like, oh, Dr. Jordan, you're so well. Yes, because Tuesday at 11, I'm with Dr. Allison. So really following up on what Dr. Parter and Dr. Simon has said, really think about who are your social supports. And if you don't have any or you don't feel comfortable, this is the time to take advantage of some of the leniencies that have happened during COVID in terms of making sure you have access to support, whether that be through a group, whether that be through professional help in terms of psychiatrists or psychologists. And I just want to uplift too, some people, y'all, we need meds, and that is okay. The same way that you need meds to get your sugar down. What do people say? Oh, I have high sugar, or their pressure is up. Sometimes you need meds in order to deal with your anxiety, to deal with your depression. There are many people who are literally going through an exacerbation of their major depressive disorder and are not having access to the tools that they need. People, I urge you, and I'm talking to my Black and Indigenous people of color and Latinx, get help. We need the tools to get through this pandemic. And some tools sometimes are accessing medication. Then the final thing, and I'll shut up, Dr. Landry, is, oh, what is the point? I'm 40, so it'll come back to me. Oh, I just want to lift up people who don't have access to technology, okay? Because if we're going to be honest about healthcare workers, not all of us have access to the ability to Zoom or connect with people. So one of the things that I just had to do for the very first time is literally send somebody a letter through the snail mail. Like, who does that? But I needed to do that because the person did not have access to an email address. So I could not stay socially connected to them while physically distancing because they don't have access to the internet. So just thinking about old school ways that you can connect with somebody. If they have a telephone, call them on the telephone. But if not, send them a letter. Because now more than ever, we have to check in on folks. It's super important. So that, again, is why we have to stay socially connected while physically distancing.
Thank you for that. And thank you for also bringing in the stigma that's affiliated with mental health, talking about the technology gap that some of us may be experiencing, and then also just bringing in folks who don't have families and are living alone. And I have a follow-up question that I would love to bring in at another point on the stigma situation. But first I want to go to you, Dr. Potter. So it's an interesting time in healthcare in that there was an article that just came out about Mayo Clinic either furloughing or cutting salary for 30,000 employees. And so we're talking about healthcare workers who are on the front line, who are caring for patients in this COVID epidemic, but they're being impacted by the business of medicine. And so we talk about wellness and we talk about how people are dealing with all of their stressors. Well, that's an added stressor. And I don't want you to answer this from more of a financial advice perspective, but just, can you talk about how these atypical times are really going to be impacting us both short and long term as we're going into the hospitals, knowing that we may be getting paid less or we may not have a job in 2 weeks?
Absolutely. I think that it's like, when there's an earthquake and you're trying to figure out a place to put your foot on, semi-solid ground. And just when you put your foot down and you think you've got it positioned, things shift again a little bit. So that's what uncertainty feels like. And it makes you feel very ungrounded. And that's a horrible way to feel. I think that the ways to combat this are very much along the lines of what Dr. Jordan was just talking about, that it has to do with finding ways to stabilize yourself that are perhaps external to this medical world of shifting tides that we're in right now. And it really has to do with the connections that we forge with other people. And it also has to do with the connections that we forge with ourselves. And if we have a spiritual practice, in that spiritual realm as well. All of these things are things that can be stabilizing. And I'd like to just say a little bit more about forging connections with oneself. There was a question that was getting at self-compassion in the chat. And I think that this is something that as healthcare workers, we're actually incredibly good at showing compassion to people outside of ourselves. We know how to do that so well. It's why we're called to this work. What we need to learn how to do and get help from our friends to do and our therapists to do is to make a U-turn and actually show that self-compassion to ourselves, because it's a very healing energy. And even if you're in the middle of an earthquake, if you can have that, you have a tremendous amount that you didn't have before.
Thank you. And Dr. Simon, I wanted to bring this question to you because I see it in the chat box and I also wrote this down for myself. But so in medicine, we're again have this belief about perfection. And then we also struggle when we recognize that one of our peers may be suffering from a mental health issue. Mm-hmm. And that stigma comes into play where when you're doing your recertification for a hospital or you're trying to come on board, if you indicate that you may have a mental health issue, that's automatically a red flag. Yet we're now talking about a situation where a number of us are now having this red flag sort of situation happening, whether it be short-term or potentially long-term. And so can you talk about how we need to step away from mental health being a four-letter word in medicine when it comes to the providers themselves? And then also how hospitals can do more to say, yes, it's okay to be stressed, it's okay to have PTSD, it's okay, whatever it may be from a mental health diagnosis standpoint, and we will still support you.
Yeah, no, it's a good question. So one, there are advocacy groups that are trying to get mental health, substance use disorders actually removed from certain board recertification or board certification platforms. With regards to how can we as healthcare providers decrease stigma? So one, conversations like this, clearly we are all experiencing something that is highly unusual, stressful and traumatic. And so this would be the great time to acknowledge that, you know, I want to talk to somebody because there's no reason why you shouldn't. And no one would say at this current time, you should quote unquote have it all together. So I think this actually creates a seismic shift that possibly post-COVID and during COVID, people will obviously just be more open about bringing it up, talking about things that are stressful, specific to hospital organizations. So for instance, I work at Boston Children's Hospital. We have an Office of Clinical Support. It happens to be housed within the Department of Psychiatry. And so if there's any clinician or healthcare worker, anyone who works in the hospital can receive some sets of services through the Office of Clinical Support. And then if it's required that you need ongoing care or psychopharmacologic intervention, they make a referral to someone, you know, in the community. So I believe most hospitals have an Office of Clinical Support. So I would encourage my colleagues across the country to seek that out, one. Two, there was a question or a comment in the chat about telehealth and telepsychiatry. Is that amenable to you know, therapy? Big answer, yes. So much like Dr. Jordan goes to therapy Tuesdays at 11, I go to therapy Tuesday at 6 p.m. And right now it's via telehealth. So sometimes it's on the computer, sometimes it's literally on my phone. I live in an apartment in Boston, doesn't have a lot of space. Sometimes I'm in my car, and it's a space where I can talk to somebody who understands what I'm going through. And it's a safe space where, again, you can know the person isn't judging you, and you can just say whatever feelings you have. So to the folks that are questioning, is telehealth amenable to psychiatry? It actually is, particularly for therapy, because if you just want to have somebody probe questions and you don't even want to see them, you can you technically can turn the video off, you can still be talking, and the person on the other end, the therapist, still can probe questions that you might feel, you know, less reticent to say if you're in office. So I think psychiatry, psychotherapy is quite amenable to teleservices. So I provide therapy, I get therapy, and we're still doing it via Zoom, via Doxamy. So I would say for those that want to try, this would be the time to seek out professional help and see if it works for you.
All right, and so I want to go to you, Dr. Potter, because you mentioned this earlier, and it's a struggle that we often have. So we as healthcare providers often see death as a failure of us doing our job. And that goes back to this whole perfectionism conversation that we were having. Can you talk about how we can better set reasonable expectations for ourselves in light of knowing that we have such little control over our work environments and also the outcomes of our patients?
Wow, that's a really great question and a really hard question to answer, I think. I think that growing up in this culture of perfection, which is instilled over so many years, especially for those of us who have the longest training, the physicians in our mix, it's really difficult to shake that culture of perfection. And of course, we always want to do our very best job. We do want to save our patients' lives. We want to make a difference. We want our lives to matter and to do good in the world. So I think that it's really about constantly having conversations with each other and being able to, you know, sort of check each other's perfectionistic roads and almost have a informal buddy system so that we don't get too far off on a side pathway because it only leads to trouble and it really is incredibly important to remain very humble in oneself in terms of what we are truly capable of as human beings. Somebody in the chat said, we're all just doing the best we can. Well, what more could anyone ask when you really come down to it?
Great. And Dr. Jordan, I know you do a lot of work around health disparities. And one of the things that we're seeing with COVID is really the exacerbation of health disparities in our current times. Can you talk about how providers, especially those of us who focus on health disparities or who come from these backgrounds, disadvantaged backgrounds, underrepresented backgrounds in medicine, how we may be dealing with both taking care of patients, but then also seeing the ramifications of the disparities in real time on such large levels on vast swaths of our communities?
Yeah, I mean, I think that in itself can be an entirely separate session, but I will definitely attempt to answer in a few minutes. One of the things that I might humbly suggest, though, is the use of the language disadvantage. I think that, especially coming from a rich history of African people and wonderful ancestors, I think that there are so many advantages to our culture, for sure. I think though we are oppressed and treated terribly in this country, there are other places in which we have full dominion and power and autonomy. So I don't particularly like the word disadvantage. Underrepresented for sure, and we often experience health disparities because we're minoritized, but I'd like to humbly just think about a reframing of that, Dr. Landry, if that's okay. But the bigger question that you are asking is one of how do we deal with kind of the mental toll, I think, that it is for many people from Black and Indigenous backgrounds and Latinx backgrounds that are also seeing a devastation of the pandemic. One of the things that I always have to center when I'm talking to folks is there's no such thing as going back to normal. So when people are like, oh, we want to go back to normal before COVID, it's like normal was terrible for many Black and brown people in this country. And absolutely not, because that just centers your privilege and, quite frankly, your ignorance about how people were living or lack thereof prior to this pandemic. And in fact, it took a pandemic in order for people to get basic rights, like access to housing, like access to healthcare, things like that. So I'd like to just really, for the folks that are still with us, just let us just abandon this language of returning back to normal, because that was terrible for many. And then just thinking about centering scholars in this field, like it's super frustrating for me to see when I turn on the news, all these white folk talking about health disparities, like really have several seats. Like there are many different Black and brown scholars who have literally devoted their life's mission and work. And I think what we need to do, and especially I'm talking to allies on the call, white people, being able to uplift Black and brown experts in the field who are doing this work and allowing them to have a platform to talk directly to these experiences. I'll finally end to answer your question, Dr. Landry, because I know I didn't answer it, but the mental health toll that it takes. I have to go back to what is normal, what's pathological. I think it's totally normal to really mourn the experience of people that look like you, even if you do not have any connection with them at all. The history of Black people in this country is one of triumphant defeat despite trying to obliterate us through Jim Crow, slavery, the Black codes, all of these things, and still being triumphant. But that doesn't mean that there is not a period of mourning that doesn't occur because of the injustices. So it makes me so upset that so many of the patients that I take care of do not have basic access to food and internet and housing. That is upsetting because I know that those will be the ones that will end up dying. So I literally have to give myself the space to mourn that. And for different people, it's going to come in different ways. For me, it's crying. I love when Dr. Potter brought in the spiritual aspect, talking to your creator, talking to the universe. For me, it's talking to ancestors. Please help me get through this difficult time. It is so much. Talking to people that have passed on, because I think you have to center the pain that is happening and allowing the space to realize that what is going on is just abominable, and yet there's not going to be anyone but us to save us. And so we have to be mentally well in order to deal with the oppression and atrocities. In order to do that, you have to mourn, but then you have to allow yourself to take care of self. So again, Dr. Potter, I'm hearing you. Compassion. How can we be compassionate towards ourselves? How can we allow ourselves to have those double stuffed Oreo cookies if that's what we need? Just allowing us to have those moments of clarity and being able to center ourselves is so super important, especially people who are coming from backgrounds of those who are the most disproportionately affected, because it takes on a different toll. And then realizing that people who, if you have privilege, use that privilege to uplift the voices who know more about the experience than others.
So I want to say just very quickly, thank you to all of the panelists for joining us and sharing your thoughts and your insights and your own personal experiences. I want to make sure that we identify some resources that are available, which you can see on the screen. I think it's really important for us to make sure that we know where the resources are and how to access them, but then also how to access each other should we be struggling. And then also for us to know how to access this information for our colleagues who may not be at that point where they're ready to reach out for help. So please take a look at this. We will make sure that we post this information available on our website and to share with you also. You have access to these resources both for children and for ourselves. Next slide. So I just want to give you all a heads up that we have a few other events that we're going to be talking about as we continue this discussion around equity and social justice, especially in the COVID era. Next Thursday at noon, we will have a conversation around our Native American communities and how they're being adversely impacted by the health disparities that we're seeing with COVID-19. Next slide. Also next Thursday, we're going to have a discussion focused around our trainees. We're going to talk about applying to residency in the COVID era, and this is going to really focus on what students can be doing as they prepare themselves to enter into this next phase of their training, although there's so much at certain times. It's also going to be next Thursday in the evening. We have an amazing group of panelists that are going to share their insights on the application process. Next slide. And I know you want to keep in contact with our speakers. So for those of you on Twitter, the Twitter handles for our speakers are here and available for you. So you can follow them and chat with them if you have any other questions. Again, I just want to thank you everyone for participating with this and joining us for this panel. It was amazing to see all the questions that were coming in. I'm sorry that we weren't able to get through all of the questions. You all have contributed a lot to this conversation. I want to say a special thank you to Dr. Potter, Dr. Jordan, and Dr. Simon for really getting this, getting on board behind this project so quickly. I mean, we came up with this idea within a week. We were able to host this amazing panel. And I also want to say thank you to Teresa, Ying, Mustafa, and all the DICP team who helped pull this together. Everything from organizing the Zoom to putting together our slides so we can have this amazing conversation. Please take care of each other, take care of yourselves. Reach out to us if you're in need. Reach out to your support networks through your institutions. And we look forward to joining you in future conversations on our webinars. Thank you and have a good evening.
8th.